present on the topics that says explain the mechanisms of action, uses of therapy of antipyretic and anti-inflammatory analgesic. We have the introduction. Analgesic, commonly referred to as painkiller, are a class of medication described to relieve pain without causing loss of consciousness. They are essential in clinical medication for managing a wide range of conditions, for acute injuries to chronic illness. Analgesic can be broadly categorized into two categories. We have the opioids and non-opioids. The opioid analgesics are known as the opioid analgesic. They act primarily on the central nervous system. They act by binding to specific opioid receptor in the brain and in the spinal cord. This binds alters the precision of pain and emotional response to it. Common opioids includes codeine. This is the most common opioid. I think everybody should know codeine. They are particularly effective in managing moderate to severe chronic and acute pain, such that are associated with surgeries, cancer, end-life cancer. However, opioids carry a high risk of tolerance, hypertension, respiratory depression, and potentials for abuse, making careful prescription and monitoring is essential in opioids. Then we have the non-opioid. The non-opioid analgesic primarily work outside the central nervous systems, although some may have central actions as well. They are further divided into groups. We have the non-steroidal anti-inflammatory drugs. These are among the widely used non-steroidal analgesics. They relieve pain by inhibiting they inhibit pains by they relieve pain by inhibiting the oxygenase sorry they relieve pain by inhibiting the oxygenase enzymes, which are essential in the biosynthesis of prostaglandins, mediators of pain, inflammation, and fever. Common NSAIDs include ibuprofen, diclofenac, just as this. This is Lofnac. This is a popular brand. It contains diclofenac and it is widely used. NSAIDs are especially effective in treating inflammation pains such as muscle-locs, menstrual pain. However, their uses is associated with gastrointestinal irritation, renal dysfunction, and cardiovascular risk. Particularly with long use or high dose of this, it is risky. We have other examples of non-steroidal we have other examples of non-opioid analgesic. We have the paracetamol. Although often grouped with non-steroidal anti-inflammatory drugs due to its antipyretic and analgesic properties, paracetamol lacks significant anti-inflammatory action. It is thought to exert its efficiency by inhibiting a variety of the cholinergic enzymes, possibly the third one, within the central nervous system. Paracetamol is widely used for mild to moderate pain and fever. It is generally safe when used within therapeutic limits, but pose a risk of severe hypertoxicity in overdose. We have other examples like based on duration and site of action. Analgesic can also be classified by their duration of action, acting on the long and the short-term duration, and their site of application such as systematic, which is oral and intravenous. We have the cream, the pouch, and the local injections. The mechanism of actions. Let us go to the mechanism of action. The mechanism of action of non-steroidal anti-inflammatory drugs such as ibuprofen. They inhibit the COX-1, which is constitutively experienced and maintains pharmacological function such as gastric mucosa protection, while the COX-2 is indisables and upregulated during inflammation. Non-selective non-steroidal anti-inflammatory drugs such as ibuprofen inhibit both COX-1 and COX-2, whereas selective COX-2 inhibitors such as Celebrex preferentially target COX-2 to reduce inflammation with fewer gastrointestinal side effects. Anti-inflammatory, let us go to the side effects of anti-inflammatory drugs. Their side effect, reducing the they work by reducing the prostaglandin synthesis. NSAID decreases vasodilation. They decrease vasodilation. Analgesic effects. Prostaglandin synthesize peripheral nonetic receptors to pain stimulus. NSAIDs relieves pain by reducing the sensitivities, particularly in conditions like arthritis. Antipyretic effects. Prostaglandins in the hypothalamus raise the body's temperature set point during fever. NSAIDs lower fever inhibition production. Adverse effect of NSAIDs. Non-steroidal anti-inflammatory drugs can cause gastrointestinal toxicity, e.g. ulcer, bleeding, due to COX-1 inhibition, as well as renal impairment and cardiovascular risks with prolonged use. Paracetamol at therapeutic dose, paracetamol is well tolerated, but overdose can lead to hypotoxicity due to the formation of a toxic metabolite in the system. Drug interaction. NSAIDs can interact with anticoagulants, increasing bleeding risks and may reduce the effects of antihypertensive drugs due to their effect on renal prostaglandins. Paracetamols have fewer drug interactions but should be used consciously in patients with chronic alcohol consumption due to increased risk of hypertoxicity. We have the pharmacokinetic profiles. Paracetamols for paracetamol it it is a widely used antipyretic and analgesic with anti-inflammatory effect. Its pharmacokinetic properties are well characterized. We have the absorption. Paracetamol is rapidly absorbed from the gastrointestinal tract, primarily in the small intestine due to its large surface area. Peak plasma concentration are reached within 30 to 60 minutes after or during administration. Food may delay the absorption but does not significantly affect bioavailability, which is approximately 90 to 60%. For distribution, paracetamol has a volume of distribution of about 0.4 kg, indicating good tissue penetration. It crosses the blood-brain barrier, contributing to its central analgesic effect. Plasma protein binds is reducing drug interaction. For the metabolism of paracetamol, the liver primarily metabolize paracetamol via three pathways. We have one, glucodenation. This is 50 to 60% sulfotion. This is 25 to 35%, and cytochloramine, which is 5 to 10%. Then let's go to the extraction. Paracetamol extracts metabolites which are extracted renally within a half-life of 2 to 3 hours in adults. Non-steroidal this next part we are going to is the pharmacokinetic profile of non-steroidal anti-inflammatory drugs. So for this, we are going to be using ibuprofen. For absorption, ibuprofen is rapidly absorbed from the GIT tract with a peak plasma concentration within 1 to 2 hours. Bioavailability is approximately 60 to 100%. Food may delay absorption but does not reduce bioavailability. Distribution: ibuprofen has a 0.1 to 0.2 kg and is highly protein bonds. Primarily, it contributes to its efficiency in arteries. Then we have the metabolism of ibuprofen. Ibuprofen undergoes hepatic metabolism, forming inactive metabolites. Then for the excretion, metabolites are excreted renally with a half-life of 1.8 to 2.5 hours. Less than 1% of the patient's drug is excreted unchanged. Let's go to the therapeutic uses of anti-inflammatory and antipyretic drugs. They are used in management of fever. Antipyretics like paracetamol and ibuprofen are the first line of treatment for fever in both adults and children. Fever is a common symptom of infection or other illness resulting from elevated prostaglandin level in the hypothalamus, which resets the body temperature at some certain point. Paracetamol is particularly effective in pediatric population due to its safe profile when dosed appropriately. They can also be used as a pain relief. Both NSAID and paracetamol are effective for mild to moderate pain, including headache, muscular, skeletal pain, and so on and so forth. NSAIDs are particularly useful for pain associating with inflammation, such as arthritis or dental procedures due to their availability to reduce prostaglandin due to their availability to reduce prostaglandin. Paracetamol is preferred for For non-inflammatory pain such as ten sion headache where inflammation is mild. In chronic pain condition such as arthritis, NSAIDs are part of the multimodal treatment approach, providing symptomatic relief with disease-defying antiemetic drugs. So we want to go to the adverse effects of NSAIDs. We have their gastrointestinal effects, we have their cardiovascular effects, it has renal effects and other effects. Another effects such as hypertoxicity, hypersensitivity, hypersensitivity and confusion in elderly patients. Toxicity of NSAIDs. Acute NSAID overdose can lead to severe toxicity, though it is less common than that of paracetamol. Symptoms include vomiting, dizziness, and in severe cases, it can lead to coma or seizure. In chronic overdose, as seen in patients with arthritis or renal or in cardiovascular complication, according to my research, they fall into coma. Then clinical presentation of paracetamol toxicity. Paracetamol overdose progresses through 4 stages. Stage 1, 0 to 24 hours. During these hours, it can just be nausea or vomiting. From 24 hours to 48 hours, we have the upright quadrant pain. For 48 to 72 hours, we have the acute liver pain. For 72 hours and above, it might lead to death or coma. Then we have the precautions to the uses of these drugs. These precautions involve conditions where this medication may be used but require careful monitoring or dose adjustments to minimize risk. The following are the precautions for antipyretics and anti-inflammatory analgesic. We have dosage and duration monitoring. For NSAID, prolonged use or high dose increase the risk of GI, that's gastrointestinal, renal and cardiovascular implications. Patients should use the lowest effective dose for short duration. Co-administration of proton pump inhibitors may be considered to migrate GI risks in high-risk patients. Those are patients that probably take alcohols. Then we have for dosage and monitoring for paracetamol, daily dose should not exceed 400 milligrams in adults to prevent hypertoxicity. Patients with chronic alcohol use or malnutrition are at high risk of liver injury, which require low dose. For drug interaction, for NSAIDs, the drug interaction with anticoagulant, anti with anticoagulants increase bleeding risks. They may also reduce the effects of antihypertensive drugs like AC inhibitors by affecting the renal hemodynamics. Then let us go to the conclusion. To conclude, antipyretics and anti-inflammatory analgesic remain ind indispensable in the modern medicine, often effective for pain relief, fever and inflammation. However, the use must be guided by a thorough understanding of their pharmacological properties, patient-specific factors and po ten tial risks. This seminar undercovers the need for continuous research and development for safer and more effective analgesic therapy, as well as the importance of interdisciplinary collaboration to optimize patient outcome. Thank you.